Welcome to the deep dive. Today, we're taking a really significant plunge into a topic that's absolutely critical if you're heading into pediatric nursing. We're talking about the complex landscape of pediatric cancer care. Our source material for this deep dive, it's drawn from key excerpts of a core nursing textbook chapter, really laying out the essentials for nursing care when children face cancer. Our mission today is pretty straightforward, but it's vital. We want to pull out the most important knowledge nuggets you need. So, understanding the underlying disease processes, recognizing those often subtle signs and symptoms, grasping how diagnosis works, knowing the main treatments, and crucially, zeroing in on the fundamental nursing care and interventions you'll actually be doing. Look, this isn't simple stuff, but it's absolutely foundational if you want to provide excellent care in this field.
That's exactly right. Pediatric oncology, it's a journey. It's filled with immense challenges, yes, but also some truly incredible moments. And being equipped with a solid understanding, knowing the disease and the specific nursing priorities, well, that makes all the difference for these kids and their families. This source really gives you that foundation.
Okay, so let's unpack this. Our source kicks off with a statistic that honestly really hits home. Cancer is the second leading cause of death in children, right after accidents. That alone tells you just how significant this topic is in pediatric health.
It really does. And it's, a stark reminder of why this kind of nursing is so incredibly important. What's particularly interesting, and the source highlights this, is how pediatric cancers often differ quite a bit from adult cancers. They frequently have an embryonal origin, meaning they come from those rapidly developing tissues early in life. The good news, they can often be more responsive to treatment, but the main challenge is that they're frequently diagnosed later, at more advanced stages.
And why is that? Why the late diagnosis?
Well, because the early signs can be just frustratingly non-specific. What might look like just a common childhood bug could, in fact, be something much, much more serious.
So the red flags aren't always, like, waving frantically. And the source lists the most common types you're likely to run into: leukemias, brain tumors, lymphomas, neuroblastoma, Wilms tumor, and various bone cancers. We'll definitely circle back to some of those later, especially focusing on the nursing angles. Okay, moving to causes. The source says it's multifactorial. What does that actually mean for us trying to figure out why a child gets cancer?
Multifactorial. Basically, it means there usually isn't just one single smoking gun. It's more like a combination of things interacting: genetic predisposition, maybe some environmental exposures, potentially infectious or immunologic factors. Your source does mention some known associations, like specific genetic syndromes. Down syndrome, for instance, has a clear link to a higher risk of leukemia. Other things mentioned are radiation exposure, certain immunodeficiency conditions, and even some prenatal exposures like specific drugs or maybe radiation during pregnancy. It's rarely a simple A causes B situation.
Right, so it's a complex interplay, not like, say, a specific bacteria causing a specific infection that makes it harder to prevent, I guess.
Exactly, which is why the focus really shifts heavily onto early detection and effective treatment.
Which brings us right to what you might actually see. You said the signs can be subtle. What are some of those general clinical manifestations the source tells you to look out for?
Yeah, this is where really vigilant assessment is key. The source lists symptoms that, taken alone could be a dozen different things. But if they persist or show up in combination, that's when suspicion should rise. We're talking about things like unexplained weight loss, fatigue that just doesn't get better with rest, persistent pallor, that kind of unusual paleness, fever of unknown origin that just hangs on, frequent infections that keep popping up, pain or swelling that seems odd or won't go away, bruising or bleeding that doesn't really match up with minor bumps, changes in behavior or maybe school performance, and persistently enlarged lymph nodes, especially if they feel firm or fixed.
You can totally see how a parent might initially think, oh, it's just the flu or maybe growing pains. It's the pattern, the persistence, that makes you think deeper.
Precisely. And that's usually the point when the diagnostic workup really begins.
Okay, so once that suspicion is high, how does the diagnostic process usually unfold, according to your source? What tests are typical?
Well, it always starts with a really thorough history and a physical exam, always. Then, the source outlines the key diagnostic tools. A complete blood count with differential, the CBC with diff, that's pretty standard. It gives you a snapshot of all the blood cells. If something like leukemia is suspected, or maybe to check if a solid tumor has spread, a bone marrow aspiration and biopsy is often needed. That's a critical procedure. Nurses definitely help with preparation, recovery, the whole thing. A lumbar puncture or spinal tap that's done to get cerebrospinal fluid and check for any central nervous system involvement. Really important for leukemias and some brain tumors. And imaging, of course, is crucial to find and characterize tumors. So MRIs, CT scans, PT scans, ultrasound, those are all in the toolbox. And often, to get that definitive diagnosis, to know exactly what type of cancer cells you're dealing with, a biopsy of the actual tumor mass is necessary.
So it's a mix of blood work, looking inside bones and spinal fluid, getting pictures, and actually sampling the tissue. Once they had that information, the source mentioned staging. Why is staging so critical?
Staging basically tells us the extent of the cancer. How big is it? Has it spread to lymph nodes? Has it spread to distant sites? And that information is absolutely fundamental because it dictates the entire treatment plan. A tumor that's localized is going to be treated very differently from one that's already metastasized.
That makes total sense.
Okay.
Treatment. This is obviously a massive part of the whole journey. The source outlines several key ways cancer is treated. Let's dive into them, focusing on what you as a nurse need to know about each one, especially those side effects you'll be managing. First up, chemotherapy.
Right. Chemotherapy. It uses powerful drugs designed to kill cancer cells. The source explains that these drugs mainly target rapidly dividing cells. That's why they work on cancer, but that's also why they cause so many side effects. A really key nursing responsibility is administering these drugs safely. Often it's through central lines like PICC lines or implanted ports, and those require meticulous care to prevent infection.
And the side effects. They sound pretty extensive. What does the source highlight that nurses absolutely must watch out for?
Oh, yeah. This is where nursing vigilance is just paramount. Chemo hits those rapidly dividing cells elsewhere in the body, too. So the source lists critical side effects like severe nausea and vomiting, which, can really impact hydration and nutrition, alopecia, or hair loss, that's huge psychosocially, mucositis, that painful inflammation of the mucous membranes all the way from the mouth down the GI tract. It makes eating agonizing. And myelosuppression.
Myelosuppression. Can you break that down?
Yes, myelosuppression. It means the bone marrow's activity is suppressed. And since the bone marrow makes blood cells, myelosuppression leads to low blood counts. So you get neutropenia, low neutrophils, which means high infection risk, thrombocytopenia, low platelets, meaning high bleeding risk, and anemia, low red blood cells, causing fatigue. Honestly, monitoring those daily CBCs and managing the fallout from myelosuppression is probably one of the most critical nursing functions in pediatric oncology. The source also mentions potential long-term stuff like infertility.
Okay, wow. So chemo hits hard, monitoring blood counts, managing those GI issues, that's daily intensive work. What about radiation therapy?
Radiation uses high-energy beams aimed at specific areas, maybe a tumor site, or sometimes the central nervous system as prophylaxis to prevent cancer spreading there. From a nursing perspective, you're monitoring for side effects in the area being treated. The source mentions things like skin changes, kind of like a bad sunburn, fatigue, anorexia, the loss of appetite, and potential growth delays, especially if radiation hits growing bones or tissues.
Surgery is also mentioned as a treatment tool.
Absolutely. Surgery is mainly for solid tumors. It could be to completely remove the tumor that's curative, or maybe just to reduce its size or relieve pressure that's palliative, or sometimes just to get a sample for diagnosis. Nursing care here involves all the standard pre-op and post-op stuff, plus considering the specifics of where the surgery actually happened.
And hematopoietic stem cell transplantation, HSCT. That sounds like the most intensive option.
It often is, yeah. It's used for specific cancers, or maybe if the disease comes back, relapse disease. The source outlines the process. Basically, it involves a period of really intense chemo or radiation, they call it myeloablation, to essentially wipe out the child's existing bone marrow. Then, healthy stem cells are infused.
So they're incredibly immunocompromised after that, like profoundly.
Exactly. That's the crucial nursing focus during HSCT infection prevention. They essentially have no immune system at first. Another major risk the source highlights is graft versus host disease, or GVHD. That's where the new transplanted cells actually see the child's body as foreign and start attacking it. Recognizing those early signs of GVHD, maybe in the skin, the gut, the liver, that's a critical nursing assessment skill.
Wow, managing those risks must be incredibly challenging. The source also mentions newer approaches, right?
Yeah.
Like biologic and targeted therapies.
Yes, and these are becoming more and more important. The source gives examples like monoclonal antibodies, which can be designed to target specific cancer cells, growth factors like GCSF, which help stimulate white blood cell production to recover from myelosuppression, and immune checkpoint inhibitors, which kind of take the brakes off the child's own immune system so it can better fight the cancer. While they sometimes have fewer systemic side effects than traditional chemo, they can definitely have their own unique reactions that nurses need to be watching for.
Okay, so Pulling all that together, really understanding what the treatment is doing and what potential complications or side effects it might cause. That's absolutely fundamental for a pediatric oncology nurse, which leads us perfectly into the core of your role: supportive care and nursing interventions. All right, let's really unpack the absolute essentials you'll be doing on the unit based on this source material.
Right. This is where all that textbook knowledge translates directly into what you do, day in and day out, at the bedside. The source organizes these interventions around preventing and managing those major side effects and complications we just talked about.
Starting with infection prevention, you mentioned it's critical, especially with neutropenia.
Neutropenia having low neutrophils means the child just can't fight off everyday germs. So the source emphasizes specific nursing actions. Private rooms are essential just to cut down on exposure. Strict hand hygiene by everyone's staff, family, visitors, absolutely non-negotiable. Avoiding raw foods like uncooked veggies or certain cheeses that might carry bacteria, that's another key measure. And that daily monitoring of the CBC is vital. You need to track that neutrophil count to know how neutropenic the child is at any given time.
Okay. Next, hemorrhage prevention because of low platelets or thrombocytopenia.
Exactly, thrombocytopenia. Low platelets means the child is at risk for bleeding. So nursing actions include giving platelet transfusions when they're needed. The source often mentions a threshold, like a platelet count below 20,000, or if there are active signs of bleeding. And crucial safety precautions are listed too. Avoiding activities that could cause injury, obviously no contact sports, but also specific things like no rectal temperatures, because that can cause tiny tears and bleeding. Using a soft toothbrush for oral care is important too, to prevent gum bleeding.
Got it. Anemia management, dealing with the fatigue and pallor.
Anemia is low red blood cells. The source notes that nurses support these children with transfusions of packed red blood cells if their hemoglobin drops significantly low, often somewhere below 7 or 8, depending on the child. Monitoring their activity tolerance is also really key, knowing when they need rest versus when they might be up for some gentle play or schoolwork.
Nausea and vomiting. Sounds like it could be a constant battle with chemo.
It definitely can be. But the source gives a really clear nursing principle here. It's much, much easier to prevent chemo-induced nausea and vomiting than it is to treat it once it really gets going. So giving those antiemetic medications before the chemotherapy is administered is absolutely critical. The source specifically mentions common ones like ondansetron and dexamethasone.
Nutrition has to be a huge challenge, too, with the NV and that painful mucositis you mentioned earlier.
Oh, absolutely. Maintaining adequate nutrition is just vital for healing and for tolerating the treatment itself. The source recommends high-protein, high-calorie diets. If the child can't eat enough by mouth, maybe because of the mucositis or nausea, nurses manage alternative feeding methods. That could be NG tubes, nasogastric, or G tubes, gastrostomy tubes, for supplemental or even complete feeding. Sometimes total parenteral nutrition, TPN feeding intravenously might be needed if the gut just can't be used. And you're right, mucositis is excruciating and severely impacts eating. The source really emphasizes that meticulous, frequent oral care using prescribed rinses is absolutely critical nursing care to manage this horrible side effect.
And, of course, managing pain through all of this.
Pain is unfortunately really common. It could be from the disease itself, from procedures like those bone marrow aspirations, or from side effects like mucositis. The source stresses using age-appropriate pain scales. You wouldn't use the same scale for a toddler as you would for a teenager to really accurately assess their pain level. Treatment involves giving a range of medications, including opioids, non-opioids, and sometimes adjuvant medications that help boost pain relief. Nurses are really key advocates for making sure pain is adequately controlled.
Wow. That comprehensive list really shows the sheer breadth of the nurse's role. It's so hands-on, it's technical, and requires just constant vigilance for all these potential complications.
It truly is. These supportive care measures, they're really the backbone of pediatric oncology nursing.
Yeah.
Managing these symptoms effectively, preventing complications, that's what allows the child to actually receive and tolerate the life-saving treatments.
And beyond the physical, there's the huge emotional and psychosocial toll, isn't there, on the child and a whole family. The source touches on psychosocial and family support.
Yes, absolutely. The source highlights that supporting the family is really integral to caring for the child. It's not just about the patient. This involves maintaining ongoing, clear communication with both the parents and the child. Providing age-appropriate education to the child about their illness and treatment actually helps them cope and feel less scared. Addressing practical needs like how to manage school during treatment, connecting with peers, even navigating the financial burdens, that's all part of holistic care. And the source mentions collaborating with child life specialists, social workers, mental health professionals. That whole team approach is crucial.
Looking further down the road, the source talks about long-term effects and survivorship. Treatment doesn't just stop having an impact when the cancer is gone, does it?
No, definitely not. And this is a huge growing area of focus. As survival rates thankfully improve, we're seeing more children become long-term survivors. But the intensive treatments they received can have lasting impacts, often called late effects. The source lists examples like potential growth and developmental delays, cognitive impairment that might affect learning down the line, infertility later in life, also an increased risk of developing secondary cancers years later, and cardiotoxicity damage to the heart muscle. The source specifically points out anthracyclines, which are a common type of chemo, as being linked to that cardiotoxicity risk.
So that means ongoing monitoring is needed, even years after treatment finishes.
Absolutely. The source emphasizes that regular, lifelong follow-up is essential for pediatric cancer survivors to monitor for and manage these late effects. It really highlights the extended role of healthcare providers, including nurses, in survivorship care. It doesn't end when chemo ends.
Okay, before we wrap up the sort of overall nursing priorities, let's quickly spotlight a few specific common pediatric cancers from your source,
Oh.
because they each seem to have some unique nursing points you really need to know.
Yeah, let's do that. Good idea. Starting with the most common pediatric cancer, leukemia.
The source focuses heavily on acute lymphoblastic leukemia, or AT-AL.
Yeah.
What's the core problem there, and what are the key signs you'd be looking for?
So AT-L involves a malignant proliferation, basically, an uncontrolled growth of immature white blood cell precursors in the bone marrow. Essentially, these abnormal cells, called blasts, just take over. They crowd out the production of healthy blood cells, so the signs and symptoms listed really reflect that lack of healthy cells. Anemia causing fatigue and pallor, increased risk of infection because the white blood cells aren't effective, easy bruising and bleeding from low platelets, also bone pain because the marrow is so crowded, and often enlargement of the liver and spleen that's called hepatosplenomegaly.
And the treatment for all often involves distinct phases, right?
Yes, the standard treatment is lengthy, phased chemotherapy. There's usually an intense induction phase to try and achieve remission quickly, then consolidation to further wipe out any remaining cancer cells, then a long maintenance phase, sometimes years, to keep the cancer away, and CNS prophylaxis, that's chemo given directly into the spinal fluid via lumbar puncture, or sometimes radiation to the brain to prevent or treat cancer hiding out in the central nervous system. Nurses are managing incredibly complex chemo regimens and all those side effects through every single one of these phases.
Okay. Brain tumor is the most common solid tumor in kids. What are the key red flags from a nursing viewpoint?
Yeah, brain tumor symptoms can really vary depending on exactly where the tumor is located in the brain. But the source lists key general signs to watch for: headache, vomiting that might not even be linked to feeling nauseous, especially if it happens in the morning, maybe vision changes, and problems with coordination or balance, what we call ataxia. Recognizing those early can be really critical.
And Wilms tumor, or nephroblastoma, that's a specific one located in the kidney.
Right, and this is a classic example of a cancer with a critical specific nursing instruction you absolutely must know. It's a kidney tumor, usually filled as a mass in the abdomen. Other signs might be abdominal swelling, maybe hematuria blood in the urine. But the crucial nursing instruction from the source, and I really can't emphasize this enough, is do not palpate the abdomen.
Okay. And why is that specific instruction so incredibly vital?
Because deep palpation, pushing hard on a Wilms tumor, can actually increase the risk of rupturing the tumor's capsule. And if that happens, it could potentially spill cancer cells throughout the abdomen, making things much worse. So when you suspect or you know a child has a Wilms tumor, gentle assessment is fine, but avoid any deep palpation of that abdomen, period.
That's a really powerful, concrete piece of nursing knowledge right there. The source also briefly mentions lymphomas and bone tumors.
It does. Lymphomas are cancers of the lymphatic system. The source differentiates between Hodgkin lymphoma, which usually shows up as painless enlarged lymph nodes and has a specific type of cell they look for, and non-Hodgkin lymphoma, which is often more aggressive but usually responds very well to chemotherapy. For bone tumors, the source notes osteosarcoma usually happens in the long bones, like the leg or arm, and often needs surgery, sometimes even amputation, plus chemo. Ewing sarcoma is a different type of bone tumor that tends to respond better to radiation therapy in addition to chemo. Nursing care for bone tumors involves managing significant pain, supporting the child through potentially life-altering surgery like limb loss, and managing chemo or radiation side effects related to the site.
Okay, cool. We've covered a huge amount of ground here from the initial stats all the way to specific challenges of different tumor types. Your source provides a neat summary of the core nursing care priorities. Let's maybe bring those together as we start to wrap things up.
Absolutely. The source really boils it down to these core priorities, which I think perfectly encapsulate the nurse's role. First, diligently monitoring for and managing all those side effects of therapy we discussed in detail. That's huge. Second, administering all medications, the chemo, antibiotics, antiemetics, pain meds accurately and right on schedule. That's paramount. Third, providing emotional support. Not just to the child, but really to the entire family unit. That's fundamental. Fourth, educating families thoroughly. They need to understand the treatment plan, how to manage symptoms at home, and crucially, when to call if there are complications. That's vital for safety and keeping treatment on track. And finally, promoting normalcy. Helping the child engage in school, play, social activities whenever possible, because underneath it all, they are still a child just going through this incredibly tough experience.
That summary really underscores it, doesn't it? It's not just about giving drugs or taking vital signs. It's about this comprehensive, truly holistic approach to care. You're managing incredibly complex medical issues while simultaneously supporting the entire family through what might be the most difficult time of their lives.
Exactly. The knowledge base, the pathophysiology, diagnosis, treatments, that's all essential. You need that foundation. But as those priorities show, the real heart of pediatric oncology nursing lies in providing that crucial supportive care, being incredibly vigilant for complications, and offering compassionate support throughout the whole treatment journey and even into survivorship.
Well, this deep dive into your source material has really, I think, illuminated the incredible depth and breadth of what's involved in pediatric cancer care, and specifically the absolutely vital role of the nurse. It's clearly complex, it's challenging, but it's also profoundly impactful work.
It certainly is. It really demands both sharp clinical skills and just a deep well of empathy.
So here's maybe a final thought for you, our listener, to carry forward after this deep dive. Given that we thankfully have an increasing number of children who survive cancer, but also acknowledging the reality of potential long-term effects from their treatments, what are the evolving responsibilities of nursing in providing that ongoing follow-up and managing those late effects, potentially throughout survivors' entire lifespan? What does true survivorship nursing really look like in practice? Thank you for joining us on this deep dive into pediatric cancer care. We really hope this has been a valuable shortcut to understanding this critical topic and the essential role that you play.